Welcome to COPD Coordinator Training, Outline of the Basics. In this presentation, we will understand COPD, the disease entity, and how it behaves. An exacerbation, which is often called a flare-up, we'll understand what it is and how it progresses, and what can be done about it. It can be prevented or treated early. We can address all points of intervention along the continuum of care. We can break the cycle of rehospitalization, and we can focus on early detection, rapid, intense intervention with no interruptions, and carry through to resolution. The role of the COPD coordinator in the system is as navigator and facilitator, person who makes it all happen. We highlight the patient's self-management. Then we'll understand the natural barriers and navigate past those barriers to assure continuity. And we'll integrate tools and checklists. COPD has a slow onset. It's easily disregarded and rationalized in its early stage. Can't breathe. I must be aging. The patient responds to COPD by becoming sedentary. Dyspnea now partly is due to deconditioning. Exacerbations are recognized late and are easily ignored by the patients and professionals alike until they have progressed beyond simple control. By the time of hospitalization, the exacerbation has already progressed to an advanced stage. Complete resolution will require much more time than a couple of days in the hospital. Thus, most active treatment actually occurs post-discharge. The healthcare system is very slow and hesitant to respond. Several pitfalls occur along the path of care where interruption may occur. So the path of care is too little, too slow, too late, and therefore too long. Now, COPD is a chronic and progressive lung disease with exacerbations. There are no cures thus far. However, all components are treatable. Comorbidities are also treatable. COPD is a combination of chronic bronchitis, where there's closing down of the airways, asthma, which also closes down the airways, and emphysema, which again closes down the airways. These conditions occur in overlapping proportions. Each one causes airway obstruction by closing down the airways, making it harder to move air into and out of the lungs. And it's characterized by airway obstruction, a heavy chest, tightness, hyperinflation, that is air trapping. Person is unable to breathe, and they become less active, consequently less able to be active, leading to disability. Now here is a pulmonary function study. The first part describes normal flow and volume. Notice that there's plenty of breathing room for both rest and exercise. However, the second curve shows what happens when a person has COPD, particularly emphysema. Breathing is limited. During exercise, there is insufficient time to empty the lungs in order to take the next breath of air. This is a microscopic cross-section of the lungs. The left panel is healthy lung. Note that the alveoli are elastic and tether the airways open. The right panel is COPD, that is emphysema, and it is getting worse over time. The alveoli become stretched and unable to tether the airways open. Thus, the bronchial passages collapse and trap air in the alveoli. Now, air trapping is further demonstrated in some patients who have emphysema at the top of the lungs and more normal lung tissue at the bottom. As the breath rate gets faster, like during exercise, the emphysema portion does not have time to empty before the next breath. The result is that the emphysema part becomes larger and bloated and crowds out the more normal lung tissue. This limits the ability to breathe and causes the patient to become very short of breath. And this whole situation is treatable by an exercise training program supported by medication, oxygen, and pursed lips breathing. COPD is a progressive illness. It impairs the ability to function in life. You can think of it in layers: the lung layer, then add the deconditioning layer, then add the flare-up layer. The impact on the patient's life includes the sum total of all three layers, not just the lung. And that's the bad news. The good news is that all three layers are treatable: the lungs by medication, oxygen, and pulmonary rehabilitation; deconditioning by exercise, helped by medications, oxygen, and pursed lips breathing. The flare-ups can be prevented by medications, pulmonary rehabilitation, and oxygen therapy. Flare-ups that do occur can be easily recognized and treated with a rapid action plan. And effectively treated, hospitalization can be avoided. Now here are the steps to becoming disabled. When a person gets short of breath, they avoid the thing that causes them to be short of breath. You get short of breath on climbing stairs, avoid that exertion. Get short of breath on walking 1 block, avoid that exertion. Get short of breath on short walks, avoid that exertion. Get short of breath on walking in the house, avoid that exertion. Get short of breath just on sitting up, so you avoid that exertion. Now you're left with being short of breath all the time and disabled. So inactivity itself is the worst disabler, worse than the disease itself. Now you can climb back up those stairs and regain the lost function. This may be a slow process, but it is well worth it. And this process should start in the hospital by a walking program, climbing back up those steps to eventually becoming abled. Now, COPD has a number of comorbidities, particularly asthma, coronary artery disease, congestive heart failure, hypertension, diabetes, obstructive sleep apnea, osteoporosis, and several others. And they all should be addressed at the same time. Exacerbation is a sudden worsening of symptoms. Patient becomes more short of breath for the same level of exertion. And there's a change in cough and sputum. Usually there's inflammation and infection involved, and it could be triggered by an environmental pollutants. Here are the main reasons for focusing on exacerbations. They are the main cause of disease progression, disability, and possibly even death. They're destructive, they're time-sensitive, and time is tissue. They are a major expense. They are preventable. They respond well to rapid action and to adequate intensity of treatment. They respond to steroids, antibiotics, and bronchodilators. So treatment includes bronchodilators, steroids, and antibiotics, and oxygen. And prevention includes medications, exercise, and early recognition of signs and symptoms of an exacerbation and rapid response. What does an exacerbation feel like? Well, breathing becomes harder than usual. There's congestion, change in cough or sputum. Airways become inflamed, they become infected, they become blocked. Inhalers don't work as well, and the oxygen level drops, and you get sick and have to go to the hospital. Progression of exacerbation starts with redness, swelling, infection, destruction, repair, and structurally inside the bronchial passages, they get roughened up. Crevices and pits develop where infection can grow, and it makes the next exacerbation more likely to occur. The bad news is they can be serious and scary events, and they may damage the lungs. Frequently, they lead to hospitalization and may make the disease worse. And the good news is that many flare-ups can actually be prevented, and those that do occur will actually be recognized early and stopped. The patient is the key, and we are their support. So in preventing flare-ups, there's smoking cessation, there's vaccination for flu and pneumonia, controller medications such as long-acting bronchodilators and inhaled steroids and combinations of those, and some physicians prescribe chronic antibiotic therapy. There are daily rituals in partnership with the doctor, pulmonary rehabilitation, and oxygen therapy if oxygen level is low. Now, an exacerbation starts with an open airway, but then it leads to redness, to swelling, to inflammation, destruction, and repair, and sometimes bad repair. Once there has been destruction, there's a long pathway to recovery. But if you catch it early, then the pathway is quite short. Using the forest fire analogy, the fire starts out small. Catch it early, we can stop it right away. But wait, we have a big job to do. And wait even longer, the entire forest is destroyed. When all it took was to catch it right at the beginning of the fire. In treating a flare-up, we manage it by trying to catch it very early and stopping it. We stop the inflammation with steroids, like prednisone, stop infection with antibiotics, open airways with bronchodilators, moisturize the airways with fluids, Mucinex, clear the secretions with bronchodilators and coughing, mobilization of secretions by walking around, airway clearance devices if necessary, stop shortness of breath with pursed lip breathing, and assure a good oxygen level by monitoring with oximetry. Now, the rapid action plan involves rapid recognition. Is the person more short of breath for the same level of exertion? Is there a change in secretions, either more secretions, more difficult to cough up? And is there a drop in oxygen level? First thing they do is call the physician, start their prednisone, their antibiotics, their inhaler medications, their pursed lip breathing, and adjust their oxygen. Patients should never run out of medications, and the doctor should monitor closely. Now, there's a cycle of destruction. It starts with a flare-up, leading to inflammation, leading to infection. Then there's destruction. And then there's repair, which is sometimes bad repair, and poor airway clearance, and another flare-up. Exacerbation management is an interactive system. You've got to recognize it early. It's got to be highly intense, with no delays, monitor closely, fully resolve, but anticipate the next exacerbation. An acute exacerbation is not fully resolved by the time of discharge from the hospital. It may take weeks or longer. So we have to have the availability of the clinician 24/7, and we've got to have management of comorbid conditions and advanced directives. So the problem areas of exacerbation is that they're recognized much too late. They're not treated rapidly enough. They're not treated intensely enough. There are poor transitions, dropped medications, restarted smoking, not treated through to resolution, and not monitored for the next exacerbation. This is the COPD chronic care map. Let's look at the details. The major headings are, upon diagnosis, outpatient exacerbation rapid action plan, the emergency room, inpatient care, transition to the home, and home care. Now, the usual point of intervention is sometime around the emergency room or even inpatient care. And the common point of disconnection is right between discharge home and getting home. Upon diagnosis, we need to assure the diagnosis. So we have to consider other conditions such as interstitial pulmonary fibrosis, bronchiectasis, and asthma. We have to consider the comorbidities such as obstructive sleep apnea, hypertension, coronary artery disease, and diabetes. We have to assure that the patient has the correct medications. We have to assess gas exchange and train in self-management and provide a rapid action plan with medications on hand. And if a person is a present smoker or at high risk of restarting smoking, then we have to do smoking cessation. Outpatient self-management via daily rituals includes medications and oxygen, inhaler technique, exercise, pursed lip breathing, and exacerbation and monitoring, and the rapid action plan. Here's the rapid action plan. Starts with rapid recognition and then rapid response. Call the doctor, start prednisone, antibiotics, bronchodilators, pursed lip breathing, monitor oxygen saturation, and adjust the oxygen accordingly. Patients must have medications on hand, and medical monitoring must be close. Now, when the patient goes to the emergency room, the treatment has to be rapidly initiated. Patients should not wait around for several hours before actually getting evaluated and treated. There should be no delay. Begin inpatient care with IVs and bronchodilators. If admitted, the treatment is already underway, and if discharged, train the patient in self-management and the rapid action plan, and connect with the primary physician. For inpatient management, acute care with IV steroids and antibiotics have already started in the emergency room. There needs to be intensive airway clearance. Bronchodilators is needed, and airway clearance techniques such as chest physiotherapy. Oxygen to maintain our target oxygen saturation, inpatient pulmonary rehabilitation with smoking cessation, ambulation, and again maintain the saturation in 92%, and pursed lips breathing, and prepare the patient for outpatient transition so the patient will have a good discharge self-management program. Discharge and transition to the home. Now, this is an important point of transition where risk of relapse is high. So we want to continue care at home by maintaining the intensity of treatment. The discharge medications should include bronchodilators, the antibiotics, and prednisone. The self-management techniques must be in place with airway clearance, oxygen during rest, exercise, and sleep. Should have a portable component as well as an oximeter. We'll continue with pursed lip breathing and smoking cessation, and the medications to support smoking cessation. Walking, refer to pulmonary rehabilitation, monitor for relapse, and quick access to the doctor. So continuing care at home must be to full resolution. There should be a home visit within the first week. We have to assure good adherence, especially to smoking cessation. Start their walking program. Proper oxygen equipment needs to be at the home, including a portable system so the patient can be mobile, and good oximetry monitoring. Disease management should take place, including the daily rituals, the rapid action plan for relapse, recognition of symptoms, rapid doctor response. The doctor office visit should be within the first 2 weeks, and again, refer to pulmonary rehabilitation. Remember that the acute exacerbation has not yet fully resolved. It will take time.
The role of the COPD coordinator makes the system work. It focuses providers on individual patient needs beyond the admission. The primary function is to serve as the quarterback, facilitating patient-centered seamless transition to the home. Early identification of the COPD patient upon admission is really crucial to the process. Ensuring adherence to evidence-based recommended guidelines and making sure that the electronic medical record order sets where available include such guidelines. Early assessment stratifying and readmission risk and determines education needs. The responsibilities of a COPD coordinator, we can take into consideration a variety of disciplines. The nurse practitioner, the physician's assistant, as well as a respiratory therapist. As a physician specialist extender at the bedside in the acute care, it's really important to assure the diagnosis and also to check and assess for comorbidities. In terms of being a facilitator, from the emergency room, through the admission, through the transition to home, and also in chronic management. The coordinator helps to arrange for resources and referrals for medications, smoking cessation, pulmonary rehabilitation, and also with smoking cessation, medications and the behavioral aspect are very important to address. There's also arrangement for post-discharge physician follow-up, which is really very important during the inpatient phase. And an educator of patient and family members. It's important to train patients to understand their diagnosis, especially if this is an initial admission where patients might be learning they have COPD with this admission. Other important information includes bronchodilators, airway clearance techniques, as well as pursed lip breathing techniques, exercise mobilization in patients that can do mobilization during the hospitalization. Smoking cessation and oxygen therapy are very important as well. Learning self-management and daily rituals is very important to prepare patients for discharge. Learning how to use a rapid action plan, which includes early detection of symptom changes, taking rapid action when those changes occur, monitoring completion of the therapy, and also when to call the physician. During the acute admission, it's important that an initial assessment be conducted. It's often the compass for what's to follow. You have to consider the readmission risk and considering using the GOLD guidelines, looking at the forced expiratory volume results in 1 second, the FEV1, if you will, and exacerbation history. These can be important in risk stratifying patients for future readmission risk. Developing a plan of care that specifies education training in the needs and early ambulation when feasible. Expedites referral needs to treating physicians, such as referrals needed for pulmonary rehabilitation, smoking cessation counseling, and medications, and also for pulmonary function tests. Checks for pulmonary function test results to confirm the diagnosis of obstruction, communicates and collaborates with bedside providers and nurse case managers to plan for the discharge. It's all in the details. Most admitting electronic medical record notes do not include information about the patient's prior level of physical function. It's very important to understand what the level of function is before patients are admitted if you're going to keep in mind of where you're going to target the discharge and what functional abilities those patients may be expected to have at discharge. What was the baseline level of dyspnea with activities of daily living before this acute exacerbation? What is the quality and the amount of social support that may be available to the patient? Is there a presence of depression or anxiety? And what was the home routine? Was there oxygen use prior to admission? Was there CPAP equipment use? Did patients use aerosolized medications to manage their disease? The COPD coordinator has a very important role and, as such, a knowledge base that needs to include understanding of obstruction of pulmonary function tests, to be able to understand the role of hyperinflation, exacerbations and the treatment of exacerbations, the significance of comorbidities that can further lend to difficulties in managing the medical care, as well as lend to the disability the patient may have, and the goal guidelines as they apply to COPD patients. The hospital-based system, understanding the structure and the players, the different providers, and how to get those providers to work together. External resources that include home care providers and also durable medical equipment suppliers. The facilitator makes the lives of all the players and providers more comfortable. It makes it easier for them when it's clear what direction the discharge is going in, and also it's more effective. Someone everyone depends on within the team. The COPD coordinator knowledge is very important. The base includes physiology, pathophysiology of COPD, knowledge about acute exacerbations, comorbid conditions such as heart failure and obstructive sleep apnea. To be able to perform spirometry and to also be able to interpret those results, blood gas analysis, oximetry, oxygen therapy, and the options that durable medical equipment suppliers provide, and also the Centers for Medicare and Medicaid criteria for the assessment and prescriptions that may be needed. Teaching techniques, and age and culture awareness when you are teaching patients. Tobacco dependency, energy conservation, and multiple benefits of exercise and breathing retraining. It basically means knowing what it takes to get the job done. So the skills that are important for COPD coordinators, along with the knowledge set, is to be able to perform spirometry, to be familiar and skilled at teach-back methodology, to be sure that patients are learning the content that's being provided, and to work in collaborative team and to demonstrate those skills. Education of the patient and family, and to basically have the vision in terms of seeing the whole picture. The coordinator competencies include the ability to perform these comprehensive assessments, to assess the learning readiness, and to be able to deliver appropriate bedside patient education on the disease of COPD, how those medications can positively benefit those symptoms that patients experience, various respiratory therapy modalities, oxygen, and the use of rapid action plans. Bedside spirometry, in the absence of spirometry from a pulmonary function lab, to at least provide some objective quantification of the severity of the chronic obstruction. Oxygen assessments for home use, including portable oxygen, and excellent reporting and communication skills. The tools and the resources of a COPD coordinator can be working with various disciplines, and that's really crucial to have a comprehensive plan for discharge. That would include a physician specialist, perhaps a hospitalist, an emergency room physician, including the primary care physician or the primary medical physician, and good coordination. Departments that the coordinator would want to collaborate with would include nursing, respiratory therapy, physical therapy and occupational therapy, social services, dietary and nutrition, and also DME and home health, good coordination across the care of the patient. Education materials are very important to have as a resource. Some people learn better with videos, providing written literature, and also websites that can be accessed even after discharge. Checklists including interventions, advanced directives, and basically resources so that they are not forgotten when they can be accessed. Ability to move the patient through the system. The interaction with the nurse case managers, the hospitalist, the primary care physician for follow-up, and knowing and being familiar with insurance coverage, being able to obtain medications and oxygen for home, and contact in the home after discharge. The COPD coordinator checklist includes assuring the diagnosis of COPD and also assessing for other comorbidities. The outpatient management includes a daily ritual with the rapid action plan, referral to early rehab if ambulatory within 1 month of discharge per goal guidelines, and oxygen if indicated, and secretion clearance when needed. Should the patient present to the emergency room, one of the interventions should be to investigate the root cause for that admission. If the patient transitioned to inpatient or to outpatient, they would use the rapid action plan. So it depends on what direction the patient is going and whether you're able to manage the exacerbation in the outpatient phase. But should they progress to the inpatient phase, smoking cessation support in smokers would be critical. During the transition, assuring medications, appropriate medications, dealing with insurance, aligning the needed resources, and maintaining the intensity is crucial. For the discharge home, smoking cessation support needs to continue and follow the patient into the home environment, and there needs to be maintenance of intense and monitored care during this important time. In summary, COPD is chronic and progressive, and all aspects are treatable. Exacerbations can be destructive, and yet they are preventable. It's important that it be time-sensitive because time is tissue. To prevent, to treat early, to treat intensely, and to treat completely, and anticipate the next exacerbation. Patients should engage in their own care, having self-management with rapid action plans and smoking cessation in those that need it. Exacerbations that require hospital care should have treatment started immediately and be monitored closely, and the transition should be a seamless one that includes medications, oxygen therapy, and smoking cessation. Treating until the job is done, and then anticipating the next exacerbation using the rapid action plan. As COPD coordinators, we have the ability to facilitate the care seamlessly across the continuum. We also have the ability to empower patients to manage their disease and better understand the treatments that they use at home, and to make a difference in the patient's quality of life on an everyday basis.
By following the comprehensive care map, we ensure that the patient is transitioned timely and intensely through to resolution. The goal is to prevent relapse and rehospitalization. The COPD coordinators facilitate the care seamlessly across the continuum.